Yes, thank you for everyone for coming. We're excited to talk about this subject. So looking over the objectives for the presentation, we will understand the anatomy and function of the pelvic floor, learn what the main pediatric pelvic floor dysfunctions are, and the treatment strategies and how pelvic floor therapy can help. So a little bit about myself. I started my college career at Delta and got my Associates of Applied Science as a health fitness specialist and a certified personal trainer. I then transferred to Central to get my bachelor's in kinesiology, and then that's where I stayed for my doctorate for physical therapy. And I've done a lot of continuing education in pelvic floor since then. My personal background, I live in Midland with my family, and we are avid hikers and campers, all the outdoor activities, and I'm also a runner. So let's dive in. Pelvic floor anatomy of a female body. So if our bodies were cut in half lengthwise like a hot dog bun, we're looking in from the side here. You can see the bladder, uterus, and vaginal canal, and then the rectum. This would be your pubic bone and your stomach on the front. This is your spine here and the tailbone on the back. We can see all of this pink under here. Those are all your pelvic floor muscles that connect from the pubic bone to the tailbone. So it kind of supports all of our pelvic organs here. And then on this side, we're looking at from the bottom up. And so your pubic bone would be here, tailbone's back here. All of the red, those are all your pelvic floor muscles. And then these are the glute muscles that are right behind there. So pelvic floor anatomy of a male body, we still have the same, pretty much the same setup. So obviously they just don't have a uterus and a vaginal canal. So the muscles are still connecting from the pubic bone to the tailbone here. And then the pelvis is just shaped a little bit differently. So the angles look a little bit different here, but still we have our glute muscles coming in, and then those are pelvic floor muscles. So functions of our pelvic floor. One of the functions is support of the pelvic organs. So those muscles act as a hammock to support the bladder, the rectum, and the uterus against gravity and abdominal pressure. So if there's a dysfunction there, sometimes that can cause the leakage when we're doing certain like higher activities like running, jumping, stuff like that. Sphincter control, so wrapping around the opening of the urethra and the urethra and the rectum to prevent leakage. But those muscles also have to be able to relax to let pee and poop out. So those muscles, again, contract to hold in, but then have to relax to let everything out. These muscles also work for stabilization. So the muscles attaching to your pelvis. It will work with your hip muscles, your low back muscles, your abdominal muscles to make sure everything is stabilized there and moving the way it's supposed to. And then we have a sump pump or a pistoning mechanism. So you can see how in this diagram here, how when you breathe in, the diaphragm's coming down and the pelvic floor is coming down. When you breathe out, pelvic floor is lifting, diaphragm's lifting. So we get this little pistoning mechanism here. So breathing is very, very important when it comes to pelvic floor health. And briefly going over the neurology of how bladders develop in kids. So during infancy into the first few years of life, bladder control is reflexive, meaning that even with small amounts of urine, the bladder contracts in response to the stretch of the bladder as it fills up. So it contracts to let the pee out as it's starting to stretch. By around 3 months, then voiding is about every hour. The awareness of the body sensations in the initial control doesn't begin until the 1st to 2nd year of life. As a nervous system keeps maturing, urinating becomes more voluntary. Control is usually established by age 3. So with this coordination that we need, the bladder contracts to let pee out, and then our pelvic floor muscles relax. So sometimes and same thing for having bowel movements. Again, the pelvic floor has to relax. So that's something we look at is the coordination between this to make sure everything's working the way it's supposed to. Oftentimes with kiddos who have pelvic floor dysfunction, that coordination's not working well. So with that being said, our main pediatric pelvic floor diagnoses, we have constipation, encoparesis, which is poop accidents, urinary frequency and urgency, and then enuresis, which is pee accidents, and that can be daytime or nighttime. So we're going to start with constipation. So signs of constipation, a huge note here is that pooping frequency isn't necessarily what determines constipation. It's also incomplete emptying, because you can have a kid that's like, oh no, they poop every day a couple times a day, but if they're only getting a couple nuggets out each time, there's still poop that's building up in there. So other signs of constipation, extra large poops that can often clog the toilet. Firm poop, so if the poop is really hard, we'll go over in the next slide the best consistency of what poop should be. Poop accidents, because when the rectum is overstretched with all that poop piling up in there, it can just fall out, because then the rectum doesn't know how to keep that in there and closed. Bedwetting and pee accidents, recurrent UTIs, because bacteria from overflowing poop can crawl into the bladder because everything is so closely related. It is more common in girls, though, due to a shorter urethra. Extremely frequent and or urgent peeing, because if there's a lot of poop there, it can squish onto the bladder and cause nerve irritation. Infrequent pooping, so if they're not having a bowel movement every day or going a couple days, that's a sign. But then also, like we said, pooping more than 2 times daily, because they're just not, it's showing that they're not getting complete evacuation. Belly pain and constipation is actually the #1 source of belly pain in kids. Skid marks or an itchy anus, because when kids have full rectums and full rectums, they're not always getting everything out, so then it's hard to wipe and some stuff is still staying there, which can cause the poop stains. Super loose poop, because the loose poop is moving around the hard mass. And then continued trouble toilet training. So looking at what the consistency of your poop should look like. So we want to be in this 4 to 5 range. So smooth, mushy snakes or mushy blobs. If we have rabbit pellets, big logs, or thick and bumpy sausage, that means that we have some constipation. And when those poops are harder, lumpy gravy or diarrhea, that probably means that they might have a stomach bug if that's short-lived, or that liquid poop is coming around the constipation. Medical tests for constipation. An X-ray is one of the best baselines you can get. Feeling the abdomen doesn't tell you a lot about constipation, because the rectum will actually stretch to accommodate the extra poop. And when you do get these done, it's called a KUB, and you want to ask in advance for measurement of the rectal diameter, because normal is less than 3 centimeters. So this gives us a good baseline, but also to know how much the rectum has been stretched out from this constipation. We also want to ask in advance for them to comment how much stool is in the rectum, so that we know how often bowels are moving. So with this X-ray, again, we can view the extent of constipation. We're getting a baseline for later comparison, but also you can have a more informed decision for if they need bladder medications, meaning if there isn't poop in the rectum, but it's stretched out and they're still having maybe some urinary symptoms, that maybe it would be beneficial to have bladder meds. But then it also helps to, if this is inconclusive and it's not showing constipation, it can give you a reason to search for other reasons why your kid's having these symptoms. Anal rectal manometry is a little bit more involved. So there's a small balloon inserted into the rectum and it's gradually inflated. The more inflation the child can tolerate, the more the rectum is being stretched by stool buildup. A normal rectal tone, we would do about 10 to 20 milliliters of air until they notice that it's being filled up. Kiddos who have constipation may not notice it until about 40. And this would be done by a pediatric colorectal doctor. Tips for improving constipation. So avoid foods that are constipating. So when you have the stomach flu, you have the brat diet. So bananas, rice, applesauce, and toast, because they're more constipating. Cheese and other dairy products can be constipating foods. Processed foods and red meats also cause constipation. Make sure they're drinking water throughout the day. You want about half the body weight in ounces. If they're doing like clear juices, like an apple juice, that might be okay. But water is the best option. When they pee, the urine should be odorless, and it also should be like a paler yellow. Shouldn't be very dark. Moving your body, so getting at least an hour of exercise in a day. When you move your body, you move your colon. And then what's another really important thing is eating enough fiber. Unfortunately, just with our American diet, we are all probably not eating enough fiber. So 5 to 7 fruits, 5 to 7 servings of fruits and vegetables a day. And a serving is what fits into your child's hand. So it could be a small apple. It could be a clementine. It could be a few things of broccoli. So it's not super big because their hands are so little. If we want to look at grams, for 1 to 3 year olds, we want 19 grams. 4 to 8, we want 25. 9 to 13, we want 25 grams for girls, 31 grams for boys. And then for 14 to 19, we are sticking at that 25, 26 range for girls, and then 38 for boys. For when you are having a bowel movement, you want to use a squatty potty or a stool for underneath their kids' feet. The phrase is hips below knees, poop with ease. And we'll see this on an image on the next slide, because with that position and with the back straight, it actually relaxes a muscle that wraps around the colon. So if this is the colon, the muscle wraps around here. So when that muscle is super tight, that's when your knees are below your hips. Whereas if your hips are below your knees, the muscle relaxes and it straightens out that colorectal angle. So that way you're not having to push around that angle and the poop can fall out easier. And then there's probiotic supplements is also another one. And then the MOP or the MOP regimen. So that is a very detailed protocol that includes enemas and additional medications like laxatives to keep the stool soft, the bowels moving, and the rectum cleared of stool. So the rectum can shrink back to its normal size. A couple notes that with laxatives, there are osmotic laxatives, meaning that it's drawing water into the colon so that poop doesn't hurt, but it doesn't necessarily clear the clogged stool. It just makes new stool softer. There is studies show that 30% of kids treated with Miralax stopped wetting the bed, but 85% stopped wetting the bed that were treated with enemas. So Miralax is good for, again, keeping poop soft so that the kids actually are able to go to the bathroom, but it's not a lifetime solution of constipation. The other form of laxatives are the laxatives that make you have to poop more. So the stimulative laxatives like Senna. So this next slide, that's the toileting posture we're looking at. So if you are just sitting and the feet are kind of dangling for kiddos because the toilets are usually too big for them, you can see how this colorectal angle here is wide because this muscle is kinking off the colon. Whereas when you're squatting and the hips are flexed, you can see the hips are flexed here. This is definitely a more straight angle. That's what we're looking for, because then you don't have to push around that angle. The poop can come out a lot easier. So for enuresis or pee accidents, that can be daytime wetting, nighttime wetting, or both. And there can be a full loss of the bladder or drops of leakage. So the American Academy of Pediatrics states that there are studies that show that almost all children with voiding dysfunction also have some form of constipation or bowel dysfunction. A poop swollen rectum, as you can see here, is going to irritate the bladder nerves, causing spasms and hiccups. A squished bladder is a smaller bladder with diminished capacity to hold urine. So the rectum can become so stretched out that the internal sphincter, which is an involuntary muscle that is inside the anus, it weakens and the poop can just drop out. And then the pelvic floor muscles can weaken by excessive holding. And then the stretched rectum loses sensation. So we kind of have a cascade of effects going on here. So going into some myths about bedwetting, sorry. The deep sleep theory is not exactly accurate because we don't eat and drink overnight. So our bodies aren't producing enough to need to pee. And when a person needs to pee overnight, it's usually because the bladder is overactive and spasming. And that can be caused by constipation or learned habits. And there's actually no studies that have shown that children with a nighttime wetting actually sleep more deeply than kids who are dry. The underdeveloped bladder theory, by age 4, the bladder is actually large enough to hold pee overnight. The urine overproduction theory, and this is the theory that some children don't produce enough of the hormone that prompts the kidneys to release less water. So no studies have shown this. There's actually a medication that tricks the kidneys into making less urine. And if this was the case for the bedwetting, then there would be a significant improvement when kids are taking this, but there's actually shown to be only a 30% success rate with that. So that's not necessarily the cause. And hereditary. There has been a link between if a parent or a sibling has bedwetting, you're more likely for the other kids to have bedwetting. But is that because they're maybe more prone to constipation instead of the actual bedwetting? So that would be something to look at. And then overall, psychological behavioral disorders, stress, laziness, or attention seeking. Again, they're all theories and they're just not backed up by science or research. Truths about bedwetting. Some children actually don't outgrow it. So 70% odds, there's 70% odds of a bedwetting 9-year-old will also wet the bed at 19. It's less likely to spontaneously resolve if a child wets the bed nightly, but then also has daytime pee or poop accidents. Bedwetting is often caused by chronic constipation because poop piles up and stretches out the rectum, which aggravates the bladder. Bedwetting should be treated by age 4 to 5. The longer the rectum remains clogged and stretched, the more difficult it is to fix. So addressing the constipation head-on helps better than medications for the bladder or bedwetting alarms, which are another 2 possibilities for treatment. Strategies that may do more harm than good when it comes to bedwetting. So sending or just wetting in general. So rewards for staying dry, because that sends a message that staying accident-free is within the child's control, which oftentimes it's actually not. For nighttime wetting, send the child to bed in underwear rather than a pull-up. Having wet clothes and wet sheets can just be really uncomfortable, and it can be very discouraging. So limiting liquids is another one. This can actually irritate the bladder and contribute more to constipation, so we definitely don't want to make that worse. Holding the urine to strengthen the bladder can actually stretch the bladder out and make urinary issues more prevalent, because then it will be hard for the bladder to know, or the muscles to know, when to contract if the bladder's full. So that can cause just leakage all the time. And then waiting to treat it. So left untreated, symptoms will often worsen and then they won't disappear on their own. So tips to improve daytime and nighttime accidents. So avoiding bladder irritants. So acidic foods, spicy foods, milk, and carbonation are the main bladder irritants. Avoiding drinking anything 1 to 2 hours before bed so that your body isn't producing urine. But drink water throughout the day. So that will help manage constipation and keep the urine less concentrated. And then emptying the bladder throughout the day. So the bladder stays the most healthy when it fills and empties on a regular basis. We want to avoid the potty dance. That means we're probably waiting too long to pee, so we're holding it for too long, but then it doesn't allow the right muscles to work to stay dry. So the pelvic floor muscles are what should be tightening when we're trying to not pee. And then we also want to avoid constipation and straining, because that will weaken the pelvic floor. So treatment options, addressing constipation, we're kind of getting a theme here. Bedwetting alarms are an option. So this can offer insight into progress with whatever treatment mechanisms you're using, and to know what time your child is actually urinating at night. Bladder medications are an option, but be aware of the side effects, because a lot of the side effects can be constipation. Some of the medications, like we talked about, will mimic the hormone that makes the bladder produce less urine. There's also other ones that calm bladder overactivity and will calm the bladder spasming. Bladder Botox is also an option, but that's kind of like a last resort. Insurance won't cover it until all other remedies have been exhausted. And then pelvic floor therapy, which we will go over how that helps in a few slides. And then, is your child ready for potty training? So toilet training readiness typically begins around 2 to 3 years of age, with most children gaining control by age 4. So look for these signs that the child is ready for toilet training. So staying dry for 2 hours. They can dress and undress without help. They show interest in using the toilet. So important to not be afraid of it. They notice when they have a wet or a dirty diaper. They can communicate the need to pee or poop, and they are willing to interrupt activities to use the toilet. So it should be noted that learning to poop on the toilet is different from learning to listen to your body's urge to poop. Because if you say like, hey, let's go try and poop on the toilet, and they're able to do it because they're sitting there, it doesn't necessarily mean that they know when their body's ready. So just give your child enough time to mature, let them kind of lead the way rather than dictate what month they will be toilet trained, because that can actually increase the risk of developing pee and poop issues if we kind of force it when maybe they're not ready. So tips for potty training success: pooping plenty of mushy, solid or mushy stools daily before training starts. So you want to see the snakes and the mushy blobs. You don't want to see logs or pellets. Make sure your child faces no deadlines, pressure, expectations. That can be stressful. You can begin around age 3, but no earlier than age 2. Children trained before age 2 have triple the risk of developing enuresis or those pee accidents. Make sure you use the tall stool for their feet. As potty training is progressing, they should continue to have good consistency of the poop. Peeing every few hours, and again, no potty dances. So frequent peeing keeps the bladder stretchy with good capacity, and potty dancing may mean your child is constipated or holding pee for far too long. Eating real foods, especially lots of fruits and veggies, because we learned that highly processed foods can cause constipation. And then when you're teaching the toilet, you can explain what happens when you hold pee and poop. So poop piles forming a big lump that squishes the bladder, causing pee and poop to come out when we don't want it to. And then holding pee can upset the bladder and make the leakage happen without warning. When potty training, sit on the toilet every 2 hours to try and pee. Show them the poop chart so they can report to you what their poop looks like maybe when they're at school. Teach good pooping posture with feet on a stool, and make sure they know that the accidents aren't their fault. So teaching your child what's happening in their bodies will help them understand what's going on and why you are making changes, if you are making changes, and why treatment is necessary if they're continuing to have issues. So what is pelvic floor therapy? We will teach proper pooping mechanics. We will do abdominal and bowel massage to help with that bowel regularity. There's modalities that we can do to help with constipation, urinary frequency or urgency, and accidents. Teaching breathing and relaxation techniques to help open the poop door, so relaxing those pelvic floor muscles so poop can come out. Strengthening core muscles to help with complete evacuation, because we need something to brace against to get our poop out. Sensory training to respond appropriately to the urges of pee and poop, so being able to recognize when our body has to go. Strategies for the school setting and dealing with social challenges related to leakage. Setting a toilet schedule, proper hygiene techniques, exercises for home, and we can, if you choose to do the mop route with the enemas, we can help with that. So the take-home message: talk to your child's doctor about their symptoms and treatment options. You definitely can advocate for yourself and for your child. Ask for x-rays to confirm constipation and get a baseline. Address any lifestyle changes that may help. See a pelvic floor PT or OT for help, and know that there is actually help available. So we have 5 different locations that do pelvic floor therapy. I know for pediatrics, both me and Celeste, who are here at Midland, do peds. I think that some of the other, maybe in Saginaw, she does peds, but I am not.
I can help with that.
Okay.
The State Street location does treat, and I know Caro does as well. The Frankenmuth and Bridgeport pelvic health specialists are a little newer to that specialty. So I think they'd be able to take on some of the more basic cases, but if they needed more advanced experience, they'd probably refer that out.
Okay, thank you.
Yep. All right. I didn't see any questions come through from our people who are attending live, so I'll go ahead and send out a last call. If anybody who's here live does have a question for Dr. Katie, please click the Q&A button and submit that now. I just wanted to say thank you for sharing this. This is definitely wins the award for one of the more interesting PowerPoints I've helped kind of with your layout and stuff like that. But As a mom myself, I know that when things are not going well with the potty side of things with kids, it can be really stressful. So it's good to know that there's some really helpful resources out there.
Yeah.
I did have one question that came in from people when they registered. They could ask a question. And she
Mhm.
said, is it normal for a 7-year-old child to struggle to recognize when their bladder is full, resulting in daily leakage?
So I would say that at that point it's not. Um, and that would probably be something that needs to be addressed. So it could be because of constipation, it could be because of habits learned. I would definitely talk to their pediatrician or their doctor about that. But that's something that pelvic floor therapy can help with.
Okay, wonderful. I just put out one last call for questions. I haven't seen anything come in. But again, everybody who registered for this webinar will receive an email follow-up that will have Dr. Katie's contact information. It'll have a couple key takeaways from today's session, and then it will have access to the recording for people who need to watch it for the first time, or if you want to rewatch it to catch some important parts. But other than that, thank you, Dr. Katie. You're always so wonderful, wonderfully informative in these presentations. We appreciate your time.
Yeah, of course.
Thank you. Bye,
Mhm.
everyone.